so much, Dr. Praveen. Now we have come to the third part of our agenda today. So we finished the two talks and a wonderful talk by Dr. Sepuri Tirmal Devi. And now coming to the real case based discussion, the managing hyperglycemia in non-critical care setting. It's a case based discussion. Next slide, please. This is my financial disclosure. Next slide, please. Yeah, this is a case wherein the male, around 48-year-old, by profession is a laboratory technician, and the duration of type 2 diabetes mellitus is 6 years, and the level of activity is moderate, and is the anthropometric measures are the weight is 69 kilograms and the body mass index is 27.8 kilograms per meter square. So this falls under the category of obese as per the Indian guidelines, and as per the Western guidelines it falls under the category of the underweight, the overweight, sorry. And the glycosylated hemoglobin is 9.7%. It is terribly out of control, and the random blood sugar is 238 milligram per deciliter, and the patient was admitted with fever and generalized body ache for 2 days, and his BP was 110 by 74 millimeters of mercury. His creatinine was 1.3 and his platelet count was 70,000. It is relatively low, but not to that extent of not low as critically low, that is defined as critically low platelet count is defined as less than 10,000 is the critically low, where the platelets have to be transfused, certainly. But this is compared to the normal figure, it is definitely low. So we have to keep the viral fevers which generally cause this particular the thrombocytopenia. That is, we have to keep the first thing is dengue fever, and the malarial parasite fluorescent technique it was negative, and we have done this NS1 antigen test that has become positive, which is specific of this dengue fever, and the diagnosis is dengue fever, and we have admitted this patient to the wards. Next slide, please. The medical history, including the comorbidities, the patient is hypothyroid for 3 years on the tablet, the LT4 75 micrograms daily, and history of type 2 diabetes mellitus from the 6 years, and no history of dyslipidemia or hypertension, no comorbidities except the hypothyroidism, and is on the levothyroxine, the dose of 75 micrograms. And the drug history, he takes tablet metformin 2 grams daily, probably 1 gram in the morning and 1 gram in the night, and tablet sitagliptin 100 mg once a day, and no drug allergies. And the patient was advised, she was advised basal bolus therapy for management of hyperglycemia. Next slide, please. Yeah, the treatment interventions on regarding the medications, all the oral antidiabetics were stopped. That was the funda of the treatment with regards to the inpatients in wards. As I've earlier told in my slides, that the only one drug that can be used is insulin. So you are supposed to stop all the oral drugs, and the total daily dose was calculated. It was with 0.5 into 69 kilos. So it comes to somewhere around some 35 units actually. So 50% of the total daily dose was basal, and the insulin degludec, so out of 35 it is roughly around 17 units were started at bedtime, and 50% of the total daily dose was bolus, that was 18 units. So we divided this insulin aspect, fast acting insulin aspect, into 6 units, like in the morning 6 units, in the afternoon 6 units, In the night, 6 units. A fast aspect was administered with meals. Next slide, please. And with regards to the discharge and follow-up, the patient was symptomatically better on 5th day. So her fasting plasma glucose was 122 milligrams per deciliter, and postprandial glucose was 145 milligrams per deciliter. Very reasonable when compared to the earlier readings when the patient was on OHS. And she was discharged on insulin degludec and advised after a fortnight with fasting plasma glucose, and I prefer to go for even the 2-hour post glucose blood sugar also. Next slide, please. Yeah, this is the case. So yeah, get back to the previous slide, please, Praveen. Yeah, I think they have done a wonderful job actually. So everything was as per the evidence-based medicine, and everything was like fine in terms of they advising the patient to get admitted for treatment, and the OAD was stopped, and the LT4 was continued, and the basal bolus insulin, that is IDEC, ASP, insulin degludec and insulin aspart were started separately. I think the total daily dose of 35 units was divided into 17 the basal and the 18 bolus. The three equal 6 units were shared 3 times, and at the time of discharge, she was symptomatically better. The fever subsided and the blood sugars were very much normalized, and she was discharged on insulin degludec. The basal insulin was continued and taking of the prandial insulin, and was advised to follow up after a fortnight with the postprandial glucose. So this is the way one has to take care about the inpatient setting in a non-critical setting actually. So if there are any questions on this case, Praveen, would you like to raise some questions, or shall we go to the next case? We'll take the questions at the end. So now you can, yeah,